Good afternoon. Guess what time it is? It is 4 o'clock in the mountains, which means 6 o'clock on the East Coast and 3 on the West Coast. Tuesday afternoon can only mean one thing. It's Fertility with Fink and Friends. I am Fink and you are friends. Good afternoon and welcome. It is so nice to see all my friends joining in. It looks like, oh gosh, let's see who got here first. Reiki Marcus looks like was number one over here on the CNY side, and number one on my side am my friend Salustio, and I always have such a hard time saying that. So one day you're going to help me pronounce it, and then I will have to stop embarrassing myself. Hello to Brooke over there on the Facebook side. So we've got a couple of different Instagram streams, and we are on LinkedIn, and we are on YouTube, and we are on Facebook. So we are just all over the place today, and it is so nice to see everyone on a Tuesday afternoon. Hey, we've got a big packed full afternoon here for you. Lots of things to talk about. Hi to Tia Cox. My friend Tailored by Taylor, who published such a beautiful picture and had such a nice transfer with us a couple of days ago, and sure was nice to have you guys here, and looking forward to the good positive news. Hi to Amber in Kentucky, of course. As always, hi to Barbara in Miami from the wonderful Miami Center of Excellence. Over here on this side, who else we have? Truth Hurts. I like that name. That's a good one. Journey to Baby W. We've got Nurse Poe, Shorty Kim, Queenie B612. Hi to Platinum Skin 24 Radiance. Ooh, that's a fancy name. We've got, oh boy, the list continues here. Boy, it sure is nice to see everybody today. Brooke is 1 week after transfer on the Facebook side, so fingers crossed over there. I have yet to see my beautiful mother and father log in here, but they claim that they sit in Alabama and watch my live. So we'll see if they come in. They say, what is that? Fertilizer with Fink and Friends? Fertilizer with Fink and Friends? No, that's Fertility with Fink and Friends, because there is a difference. It's not quite the same thing. Well, let's see here. Oh gosh, Journey to Baby W, Ebony and Tim headed to the Springs soon for retrieval. That is such a good thing. So nice. Hey, listen, I want to start out today by talking about something that has been an ongoing question, and hopefully it is something that may be of interest to you and of use to you in your life. And that is one of the things that we as gynecologists deal with really on a, certainly on a daily basis. And I suspect really you could say that anyone with a vagina deals with on a daily basis. And that is the question of vaginal discharge. And it's always funny because, when if you ever go have dinner with gynecologists tend to talk about things like vaginal discharge over dinner. And sometimes things get a little too loud, and you look around and you see that other folks in the restaurant may not be as comfortable talking about vaginal discharge. Funny how that works. Why do I say that anybody with a vagina may have something to have some knowledge of vaginal discharge? Because everyone has vaginal discharge. It is completely normal to see some discharge in your underwear, or if you wear a pad. Sometimes it can be so much that you even have to kind of wear a pad. What's normal versus what is not normal? And it can sometimes certainly be enough to kind of drive you crazy. So let's talk for a few minutes just about what discharge is, what it comes from, what's normal and what's not, so that you will know. Well, so the vagina is very much of an alive place. If we took a little swab and we looked under the microscope at that swab, we would see a bunch of different things. We would see a lot of little bacteria floating around. And if you're not used to seeing that, you would look at it and you would say, oh my goodness, what is that? Where did that come from? It's normal business. That bacteria is called lactobacilli. The lactobacilli is the normal bacteria that live in the vagina and which we expect to be there. In fact, it's that bacteria that that maintains the normal chemical environment, or the pH of the vagina, and that's what keeps the vagina normal. It's when that bacteria gets knocked off kilter that people start having problems, because when the normal chemical environment of the vagina changes, it allows things to start overgrowing and to start causing problems, and that can be the type of discharge that becomes annoying, and things that you may certainly be aware of. There's a lot of skin in the vagina. Would you not agree? It's lined by skin. The skin of the vagina, the folds of that mucosa, as we call it, are called rugae. That rugae, those rugal folds, as we approach the time of the menopause and the estrogen levels drop, that skin starts to flatten out, and some of those rugated folds start to disappear. Well, if you remember anything from second grade science class, when we would take a toothpick and scrape the inside of our cheek and put it under the microscope and look and see, we are constantly sloughing off cells. Well, you would agree with that, I would imagine, right? So if I sat here and rubbed my arm for long enough, I'd start to see some dust kind of fluttering around, and that's the squamous skin cells, the squamous cells that make up the skin that start to slough off. That same thing happens in the vagina constantly, and those sloughed off dead skin cells serve as the source of food for the lactobacilli, the normal vaginal bacteria. That vaginal bacteria produces hydrogen peroxide. Now, hydrogen peroxide from, well, if you pour it on a cut, it kind of foams up, right? Well, it's not the same concentration of hydrogen peroxide, but that hydrogen peroxide is what maintains the normal vaginal pH, or the chemical environment. So what can go wrong with that situation? Well, certainly we know that as your cycle changes, with the menstrual cycle, the vaginal discharge will change, and that's to be expected. So around middle of the cycle, when you're going to ovulate, the cervical mucus, the job of the mucus that comes from the cervix, is designed to say, come on in here, to grab sperm and help to kind of pull it up inside the vagina. So mid-cycle, that cervical mucus becomes thinner. It becomes more watery because it's becoming more welcoming to the sperm. So that's some sort of normal cyclic variation that has to do with the menstrual cycle. But what can go wrong? Well, when the pH gets knocked off, when that normal lactobacilli becomes abnormal, the most common vaginal discharge for women is called bacterial vaginosis. Now, it's funny because most people think, and as a gynecologist, we hear this all the time, that, oh, I have a yeast infection. It's a yeast infection. If I have vaginal discharge, it's just a yeast infection. It's sort of like, sort of taking one of these and saying it's a Kleenex. Well, it may not be a Kleenex. This may be, some other brand, but Kleenex is kind of what we think of it as. And many people think of that vaginal discharge, it must be, it's yeast infection, right? Yeast is not the most common thing that happens in the vagina. Bacterial vaginosis happens when there's an overgrowth of that normal bacteria, of one of the normal bacteria that lives in the vagina, that causes the normal lactobacilli in the vagina to start to diminish. And when that happens, these things are happening kind of simultaneously. The lactobacilli is diminishing, and the abnormal, or in the other bacteria, is overgrowing in an abnormal fashion. That causes a discharge that's sometimes white, it's sometimes yellow, it's sometimes greenish, and it has a particular odor to it. It's usually a very fishy odor that is most prominent often after sexual intercourse, and that's because if semen gets into that into that discharge, it causes the odor to be worse. So vaginal discharge with odor is almost always going to be bacterial vaginosis. A yeast infection. So yeast is also one of the normal organisms that live in the vagina, but when it becomes an infection is when things get overgrown. And typically causes a cottage cheese-like discharge that's very inflammatory. It's very itchy. Most of you, if you've had a yeast infection before, you know what it's like. But some people, sometimes you can't tell that's what it is because it may not be the classic appearance of yeast, that sort of cottage cheesy looking stuff. It may just be a thin white or gray discharge that's just itchy and bothersome and stings and is irritating. Now, bacterial vaginosis as well sometimes can be irritating on the skin. So you can't tell just from the symptom. Now, if it's a very obvious yeast infection to you, then you know it's a yeast infection, and that can be treated over the counter. Those creams are now available. They're available without prescription. Bacterial vaginosis requires a prescription to treat, and there are some different options for doing that as well. And then, of course, there are some less common types of discharge. So there's certainly sexually transmitted infections. There are some things that you've probably never heard of before that can cause vaginal discharge. And in fact, there is a type of yeast that is resistant to the classic treatments. And so sometimes people will come in and say that they have a chronic infection in the vagina. And when we test for it, it's one of the non-standard types of yeasts. And so this is a good reason to go kind of get it checked out, because we can culture that. Usually we can use even just a single little swab that will tell us everything that we need to know. So some discharge is normal. You can expect that you have some. Everybody has some, and that can vary during your cycle. And hopefully that is some information that will be useful to you. So now you know everything there is to know about vaginal discharge, and you guys can fill in for me when I go on vacation, right? I appreciate that. Thank you. Well, in my peripheral vision here, I have seen an awful lot of little things going in to my feed there. Lots of questions and lots of thoughts and comments. And so let's see if we can get started with that. Going back over to Facebook, let's start there. Marissa Ham. Hi, Marissa, glad to have you here. Rachel Chambers has a question about metformin and inositol. Should both be taken together for egg quality, or is one better than the other? That's a very good question. Metformin versus inositol. Inositol is a supplement, and it really does the same thing as metformin. So in my opinion, you probably don't need to take both of them. They really are the same. In most cases, when I talk to a patient, if they're not already taking inositol, and we find that we need to use some metformin or need to use this combination for egg quality, I'll usually recommend the medication. Why is that? Because first of all, it's probably a little bit cheaper. We keep losing some connection over here on this. And so let's see if we can do a better job without the Wi-Fi. Hopefully that's a little better on this Instagram feed here. We don't keep losing it. Metformin is probably a little cheaper because your insurance will cover that. It's probably $10 or something for a month's supply of it, whereas inositol might be $25 for a bottle because it's a supplement. The other problem that happens with supplements, even though there are some wonderful supplement companies out there, is that they are not regulated by the government. So they can say whatever they want to say. Their manufacturing practices can really be kind of whatever they want them to be. And so when they've done some studies and they went into some place like the GNC and they pulled a bottle off the shelf and they evaluated what was in each pill, that there was often a wide variation between what was from pill to pill, what was from bottle to bottle, and what was on the label versus what was actually in the bottle. And so we just never really know about the quality of supplements. Again, even though there are some very good supplements and some really wonderful manufacturers out there, I think when it comes to metformin, it's cheaper and it's going to be more reliable because it is pharmaceutically manufactured. Now, the pharmaceutical manufacturers have to abide by the government's rules for manufacturing processes. So you can be pretty assured that what's in one pill is going to be the same as what's in another pill, and that what's in there is what they say is in there. So that's kind of the difference between metformin and inositol. Rachel, really good question. Andrelina, hi, sorry for the name there. Andrelina Rodriguez, nice to see you today. Day 11 of a medicated frozen transfer cycle. And the lining is at 6.6, and there is some fluid seen. Well, so I am a little concerned about that lining being thinned at 6.6, and sometimes that fluid can be a sign of some inflammation. So as you're getting a little closer, you're in a medicated cycle there. So they should have, we want it to be above 7 millimeters at the time that you start your progesterone. So not sure where that fell in there, but Andrelina, I'd be a little concerned about your lining right now, especially with that fluid. We'd like to see that fluid not there. Sometimes taking some Mucinex will help that fluid to absorb and be gone by the time of your embryo transfer. So hopefully that's helpful. I do see my beautiful mother has joined, and hopefully my father is with her instead of off causing trouble in Alabama. So hi, nice to see you. All right, let's take a look here, because I see the CNY Instagram side has been very busy. So let me go back up to the top here, and let's see if we can start to answer some of your questions. Chronically Ill Mama. That's a very nice name. I like it. I like it. Okay. All right. Looks like somehow or another the feed dropped there from my Instagram over here. So let's see if we can get back in there. Okay, the Flying Petrella, excited for our appointment at CNY in Albany on Friday. That sounds fantastic. Retrieval, Queenie Bee has a retrieval on Thursday with us here in the Springs. And that is going to be a good time had by all. Proud Mama asks, why do you suggest against a fresh transfer if someone has an estradiol of over 2,500? Is it still possible to get pregnant with a fresh if you transfer with an E2 at that point? Well, so to be honest with you, the number is really not 2,500. We typically use the number of 3,000. So if the estradiol is above a 3,000, that's your estrogen level above a 3,000, then we get worried about that, because it means that the lining of the uterus is just really not hospitable for an embryo transfer. And basically what that means, it's sort of like taking a beautiful embryo and putting it into a burning building. And that doesn't sound good. You invested an awful lot to make these embryos. So if the lining of the uterus is not hospitable, then it really becomes worrisome that it won't be a good place for that embryo to try to grow. The number that we use is 3,000. People being extra conservative may say 2,500 because it's getting close to 3,000. But in reality, I would use that number of 3,000. So that is the reason, Proud Mama. Hi to Grace. Nice to hear your, nice to see your nice to see your name. I say nice to see your face. I don't see your face. A doctor recommended I had my cervix dilated before my first transfer. It's about a year later, and I'm wondering if I should do that again before more transfers. Probably not, Grace, because we're pretty good at getting into a cervix, and so if if there's any issues, usually we can bridge that at the time of embryo transfer. So you probably don't need to do that again, would be my guess. All right. Who knows, Crystal? Hello, tomorrow is my egg retrieval in Syracuse, but I'm scared because they have to do an abdominal retrieval. Is it more painful? And is it done regularly? Yeah, actually, an abdominal retrieval is really very easy. It's just we place the probe on the abdomen, and we're able to kind of see right down in. The same little needle goes inside. It is not more painful. The ovaries are going to feel the same way. Usually put a little Band-Aid on the abdomen afterwards. It's pretty common that I will reach for or have to take a look abdominally when doing a retrieval because, sometimes the ovary is just in a position where you can't so much see it vaginally. But don't be frightened. It's a very straightforward business. And should be nice and easy to do. I am not sure if my Instagram came back yet over here. I think it was my personal Instagram side. Looks like, oh, there it is. It's back again. I think we're having some connectivity issues over there with my Instagram, but thanks for sticking around. Oh, let's see what else we have going on here. Susanna Smith on the Facebook side. I have 10 eggs frozen, and I'm doing around next week and making embryos to freeze for later. I have diminished ovarian reserve, and I don't think I'll get a lot. Should we genetically test the embryos now and then freeze? Should we thaw the eggs now and fertilize and then genetically test them all? Okay, well, so you ask good questions, and hi again to everybody who is rejoining on my Facebook side, my dear friend in Miami. Howdy. So Susanna, the answer is, I think the PGT testing is really best used for when you have a large group of embryos and you are trying to help to separate out those that will give you the highest probability of pregnancy. And so if let's say that you have 10 embryos. If you have 10 embryos, well, that's a lot of embryos, and that's potentially a lot of transfers to have to do until you get to the few that may be normal, because they all won't be. That's the benefit of PGT. So if you had just a couple, let's say that you were going to do a retrieval and maybe you got 2 eggs, and those 2 eggs, let's say they both fertilized. I would not recommend that you do PGT testing on 2 embryos. Why not? Well, the truth of the matter there is that you can place those embryos inside of you and they're either going to stick or they're not, right? Because they're either normal or they're not. And if they're not normal, they're not going to stick. So do you really need to pay the lab to do that testing when your body is going to give you the same information? Plus, the other problem is that when you've got just a couple of embryos, we have to grow them out to the blastocyst stage, which is typically a day 5 or a day 6 or sometimes a day 7 embryo. Well, they may not grow. And so in that situation, we would always rather see that embryo going inside of you than an embryo potentially dying in the laboratory, because you and your uterus are always going to be a better environment than really anything we have in the lab. So by that token, if it's a couple of embryos, we really want to see them either frozen or going inside of you. Now, if you've got those other 10 eggs that are frozen and you're going to fertilize them, then odds are here now you may have a whole bunch of embryos, and then doing the PGT testing probably makes sense. So Susanna, best of wishes with that. Good luck. Janine's asking if an AMH level comes back high, suggesting PCOS. Is there a way to get a good idea of the actual reserve? So the AMH test, as we know, is a test. The anti-Mullerian hormone is a test of ovarian reserve. And when that number is high, it is suggestive of polycystic ovaries, which means that your ovaries are probably going to respond pretty well to the medication. So that really kind of is an accurate reflection of the reserve, that someone with polycystic ovaries probably has more eggs sitting in those ovaries, waiting to respond to the medication. So that's kind of the way I would think about that. And it looks like Alicia is here with us as well. If someone has poor quality eggs and they have degenerated in the past, would you recommend ICSI, or would you recommend, she says, natural fertilization? And that we mean what we call conventional IVF. Conventional IVF is where they take sperm and they just sort of put the sperm in a petri dish, if you will, with the egg, and expect that sperm to penetrate the egg and fertilize it. That's what's called conventional IVF, as opposed to ICSI. ICSI, ICSI, is intracytoplasmic sperm injection. And that's where our embryologist selects one individual sperm and places it directly into that little egg so that we can fertilize it directly. At CNY, our usual protocol is that everybody gets ICSI. And in fact, in most clinics, ICSI is really the standard of care. There are some places that will still do conventional IVF because they want to charge you more to do the ICSI. CNY does not charge anything extra for ICSI. The problem with conventional IVF, and there are some people who say, well, I just want to do it as naturally as possible. And I would submit to you that there's really nothing that's all that natural about doing IVF. So I'm not sure that logic really holds. But if you do conventional IVF, just putting the sperm on the egg and expecting the sperm to do what sperm are supposed to do, then what can happen is that the egg doesn't fertilize. And if it doesn't fertilize, if the sperm can't penetrate that egg, then they have to do what's called rescue ICSI, which is like the next day they'll try to take one of those sperm and do the ICSI procedure. But when that happens, typically the outcomes are very poor. The fertilization rate is very, very low. So in general, we have found that doing the ICSI upfront, ahead of time, instead of trying to do conventional IVF, is usually the better options. Now, if the eggs have degenerated in the past, sometimes that is an indication to do conventional IVF. So I certainly think that is worth considering. Let's see what else we got going on here. We've got a whole lot of people watching on this side. Carrera Webster has been driving from Oklahoma, and you're almost here. We'll see you tomorrow. That's outstanding. Have a safe drive. And let's see what else we have now. Monkey Mo says, I went for a beta on Friday and it was positive. I went in on Monday for beta 2 and it had dropped 1 point. Along with my progesterone, does that mean it failed? Well, I would say that doesn't bode for positive things, because typically we expect that beta HCG, the pregnancy hormone level, to double in 48 hours. If it has plateaued, if it's not going anywhere, then that suggests that the pregnancy is not continuing to grow. Now, the thing that we always worry about in that scenario is, well, where is the pregnancy? Is the pregnancy inside the uterus, or could this be a pregnancy that's in a fallopian tube? Because the fallopian tube pregnancies, which we call ectopic pregnancies, are more common in folks who are in the fertility population, in our fertility world. So that's something that we really want to watch out for very carefully, Monkey Mo. So best of luck there. We want to keep right on top of that hormone level, okay? We had our fourth transfer of 3 day 3 embryos at Syracuse with Dr. Banerjee today. The first was a modified natural, and the P4 came back at 24, which is good, but the estrogen came back a little low. Should I be concerned? The answer to that, and that is from my friend, and you're going to make me pronounce the name again, M. Salustio. I think I said it right. Thanks so much for being here, by the way. I think you're here every week, and I notice it, and I really do appreciate that. Should you be concerned with an estrogen level with a natural embryo transfer cycle? The answer is no. Why not? Because estrogen really has one job. And the one job of that estrogen is to build up the lining of the endometrium. So if the lining was normal, then the estrogen level really doesn't matter. Why do we even test it? This is something that we internally at CNY have debated again and again and again. Why do we test it? Well, because if we don't, then people ask for it. They say they want it tested. And so, we're sort of damned if you do and damned if you don't. But the answer is that the actual level of that estradiol level in a natural cycle is not important. What is important is that the lining of the uterus has gotten thick enough. Let's see if anybody else has joined over here on mine, and they have. So we had a little Instagram connectivity issues over here on my account. So apologies for that. And away goes Paige is here. Or away Paige goes. I'm sorry. I don't want to get that wrong and offend anyone. Natural cycle FET, is there wiggle room if best transfer day lands on a Sunday? Well, so since we're not open on Sundays, you can't do it on a Sunday. And so usually what happens in a natural cycle is that we would cancel it if it would really kind of be on a Sunday. Because there's really kind of a precise window, a precise amount of estrogen that we're looking, or I'm sorry, a precise amount of progesterone that we're looking for in order to make that lining the perfect place for your embryo. So that's one good argument to do a trigger shot if you're doing a natural or a modified natural FET cycle, because when we see that the egg, that the follicle is of a mature size, we can trigger the ovulation. And that way we have some control. And usually that means you're going to have your retrieval about a week later. That means that we have some control over when that is going to be, as opposed to letting yourself ovulate naturally. Means it may fall on a Sunday, and then it really isn't the best idea to try to put it in early or late. So Paige, hopefully that helps you. Hi to Brandis, who has joined us here. Oh, and my friend Alex has joined, who is in Costa Rica right now, I believe. And hi to the lovely and talented Jody Hoffman, nurse extraordinaire in Missouri, formerly of Colorado Springs. If you're just joining, it's about 32 minutes after the hour. We have about another half an hour here on Fertility with Fink and Friends. Every Tuesday night, we try to get to all your questions, but gosh, I am just not good enough at being able to get to them all. So thanks for working with me and sticking around here, and let's see what we can do. Miss AK says, I am going to do a Neupogen wash with my upcoming 5th transfer. Do you suggest Neupogen injections as well? I'm not sure I can afford both, but want to be successful this time. Well, by your 5th transfer, my friend, I am sure you are getting tired of the whole process, aren't you? Neupogen is a medication that revs up your immune system. It's part of our level 3 immune protocol. And what we see it does in your blood is that it makes your white blood cell count go up. And so anybody who's ever been on Neupogen knows that you may have a white blood cell count of like 30,000 or something. So yeah, that would otherwise be very concerning, because it would mean, gosh, do you have some very bad infection? But we want it to go up because those white blood cells are helping to protect against autoimmune things and inflammatory things that are trying to keep you from getting pregnant. If you have done the Neupogen injections before and you haven't done the Neupogen wash, then I would say this is a good time to do the Neupogen wash and then try to skip the injections. If you've been doing the injections and you haven't done a Neupogen wash, try to change it up, and let's see if something here can make a difference. It is a very expensive medication, so I certainly understand that you might not be able to do both, but I do think a Neupogen wash is probably a really good idea for you at this point. Let's see what else we have here. Does Zymot, this is from Jay DeRoe, who has a picture of a cute little doggy there. Does Zymot improve sperm selection for embryology. So what Zymot does is that it's what's called a swim up method. And it's a little device that is designed to mimic something like the fallopian tube. And so all sperm goes in on one end, and then theoretically, it's the best sperm that swim out the other end. And that's sperm that may be morphologically more normal, sperm that look normal, that have normal heads and normal necks and normal tails, sperm that swim better, better motility, and more importantly, sperm that might have less DNA fragmentation. Or, because again, as I like to say, what is a sperm? It's a little package of genetic material with a tail, with a motor, right? And so if the motor is going to let the better sperm swim up through that thing to come out the other end, that's the premise behind Zymot. And it is probably helpful in folks who have some male factor issues, who have a high level of DNA fragmentation. And if you believe the data that comes from the company that makes the Zymot, is probably a good thing to use in folks who have unexplained infertility, because there is something that we're not finding, and part of that something may be in the sperm. So Zymot is a $200 add-on. It is not a $2,000 add-on. So given the affordability of the price, it may just make a difference. And so my opinion has changed for the positive about Zymot. Some call it Zymote. I think Zymote is technically the correct pronunciation, but we're lazy around here, so it's easier for us to say Zymot. Don't tell them we said so. So did I have something else I wanted to say about it? The only thing about Zymote is that you have to have an adequate number of sperm. The sperm count has to be adequate, and enough of them have to be swimming in order for the Zymote to be useful. So if the sperm count is less than 2 million, that's really not enough to use the Zymote. And what may end up happening is that nothing comes out the other end of it, that there's not enough of them that will be able to swim through to give us enough sperm to be able to fertilize eggs. So motility and sperm count are required for the Zymote. Tailored by Taylor, my friend in the beautiful picture from before. My estrogen dropped at the midway blood work. What does that mean? It doesn't mean anything. As I just said, your day 4 post transfer, and estrogen level, there's really no good reason for us to check it. It really just has to do with, was your lining thick enough at the time of trigger or at the time of progesterone start? So don't worry about that, Taylor. I think it's all going to be good. And I have really good vibes about your transfer because it was a really good picture you took. So thank you for that. Let's see here. I see my friend Zenita in Miami. Hi, Zenny. Thanks for being here. I almost had a donut in your honor today, but there were no Krispy Kremes present. So alas, it couldn't be done. Krispy Kreme is kind of a weakness around here, or at least in my office. Krispy Kreme is a weakness. Let's see what else we have here. I think I skipped a question up top. Let me see if I can find it. There is from Ethan. And the question is, my wife's AMH of 2.165 at the age going on 43. It's a very good AMH for 43 years old. We talked about the quality of eggs and said it was good. Her count was good. She takes prenatal with omega-3 and CoQ10 supplements. Been taking it for 2 months. Would you recommend she takes anything else for egg quality? And is she a good candidate for a modified natural? So you're asking 2 important questions there. First of all, who is a candidate for a natural versus a medicated cycle? So my friend, I would tell you that the best candidate for a natural embryo transfer is natural cycle is someone who has regular periods. If your periods are not regular, then we can do a modified natural. And what that means is that we are giving you a little ovulation induction. It's a pill that you take for 5 days that'll make sure that your ovary is going to release the egg, because that whole process is how you make your estrogen and how you make your progesterone. So I would say, based on what your describing there, yeah, she's probably a pretty good candidate for either a natural or a modified natural, for sure. You ask about egg quality, and yes, egg quality is probably the most important thing there is as it pertains to this process. So there is a book. It starts with the egg, which happens to be, and I show this oftentimes. It starts with the egg. Um, this is kind of the world's Bible on what can a handful of vitamins do for human reproduction. It turns out they can do a lot of things. So this is a very well researched book. There are some protocols for diminished ovarian reserve, for normal ovarian reserve. And if you would like to instant message me or message me through Instagram at RandyFinkMD, I'm happy to send you that list. It's another great supplement that is on the molecular fertility website through CNY that's called Ovarian Bloom, that has many of the things in here. And so things to know there. Hopefully we can help with that. Angel Harris said, I had my first telephone appointment today for IVF. What can I use for egg quality at the age of 41 with no kids? Well, there we go. Boy, I just answered that question. How wonderful. At Randy Fink MD, and I am happy to provide that list for you. Alicia says, we've been prescribed Plaquenil. When does one start taking it? So certainly at the time of Plaquenil is part of our immune protocol 3. So certainly by the time your embryo transfer cycle begins, you should be on Plaquenil. Sometimes if we believe there's enough inflammation, we will start folks on the Plaquenil before they actually begin. So let's say that you're planning to do your FET cycle in November, we may just have you start the Plaquenil now. It's a fairly innocuous, benign medication that has been around for 70 or 80 years. So it is something that's considered safe to take. So certainly at least by the time you're starting your embryo transfer cycle, but sometimes ahead of time as well. If you'd like to go ahead and start it, I see no harm to doing that. Nurtured Shanna says, what is the test for natural killer cells? I'm not sure if I've ever had that done. Natural killer cells, or NK cells, are a type of immune cell that that can try to attack your embryos. The problem, and the test is just an NK cell test. The problem is that when you test for it, it's looking at the number of NK cells, not so much at the NK cell activity. And the NK cell activity is really what's most important. So I don't recommend that we routinely test for NK cells, because we at CNY anyway routinely treat for NK cells. And that's one of the major purposes of the intralipid. So if you've done an embryo transfer cycle with us, you know that you get that little kind of milkshake IV looking thing around the time of transfer. We often recommend that you continue on that once weekly through the first trimester. That is the treatment. Intralipid is the treatment for NK cells. And so in my opinion, it is better to just treat it than it is to test for it, because the test may have both false positive and false negative. Let's see here. Oh, my friend Nikki Jones Fit. Hello, Nikki Jones Fit. Nice to hear from you. How would it be for someone to not place the embryo in the how easy would it be to not place the embryo in the perfect spot during an FET? Well, so what we do during an embryo transfer is that the catheter should be just right above what we call the internal os, which is the internal opening of the uterus. And that's why we use ultrasound to identify that place. We then gently place the embryo inside. Where the embryo goes inside is kind of going to depend both on the lining of your uterus as well as on some factors about the embryo. So, placement is important because we want to give really the entire uterine cavity as a location for that embryo to find its way to where it wants to go. What would not be proper is to take that catheter, put it all the way up at the top part of the uterus, which we call the fundus. Doing that obviously limits where that embryo can land. So we want to give it as much room as possible. And that's said to be ideally approximately 2 centimeters away from the fundus, which is probably going to be just above the inside of the uterine cavity. So how easy would it be? Well, we do this a lot. So usually, it's done correctly. If you're having an embryo transfer done by someone who's never seen one, who's never read about it, or doesn't know how to do it, it'd probably be pretty easy to put it in the right place. But just like it could be easy to put it in the wrong place, it's very easy to put it in the right place. So that's kind of what we do. Good question, Nikki. Nice to hear from you. Proud Mama says, if your estrogen is higher, but is brought down with medication prior to transfer, then does it raise your chances of a successful transfer? Oh, I see. That's going back to the question about level of estradiol for a fresh transfer. So one of the things that CNY does a lot is that we use a lot of the medication called letrozole. Letrozole will lower your estradiol level. But if your ovary is hyperstimulated, it really has to do with the ovaries and the whole factor of the ovaries, not just what the number is. The estradiol is a reflection of kind of what's happening on the inside. If the estradiol is artificially kept low by the letrozole, then still doesn't bode well for a fresh transfer. So usually we're able to kind of just, even if the estrogen is low, we're able to take a look. Sometimes the progesterone level will go up since the estradiol can't. If that's above a 1.5, fresh transfer is a bad idea. If we take a look at the ovaries and they appear to be hyperstimulated, that's lots and lots of follicles, a lot of fluid inside the pelvis, then we will likely advise you that a fresh transfer is ill-advised. And again, a lot of times people get really upset about that because they have their heart set on doing a fresh transfer. It's included in the price at CNY, that fresh transfer. But the truth is, you really, you invested a lot to make those embryos. So you want to do what's going to work, not something just randomly because it seems like you thought it was going to be a good idea. You know what I mean? So let us guide you on that. And hopefully we know when folks want to do a fresh transfer. And so we try to let you do that whenever is possible. But yeah, you raise a very good question there. This comes from Go CF, I think that is. I have a problem with high blood pressure, and I know that intralipids isn't recommended. What would you recommend instead of it for NK cells? Well, the second option is, so the reason that people say don't do intralipid if you're hypertensive, if you are, if you have well-controlled hypertension, you can still do intralipid. If you come in here, for your lipid infusion and your blood pressure is, 220 over 110, we are not going to want to put an IV in you and put extra material in your blood supply because the blood pressure is already very high. If it's controlled, you can still do the intralipid. But if not, then that's one of the other things that prednisone will also help with. It will help to decrease the NK cell activity. But that was a really good question there too. Thanks for the good question. Okay, what else we have here? What if intralipids haven't helped the NK cells? What would be next? Well, so again there, and this comes from CC, aka Pinky. The number that you get on your NK cells may not change. Now, sometimes the prednisone can change that number, but what's important with natural killer cells is the NK cell activity, which is something that's happening at the cellular level that you really can't measure. So your number may stay the same, but intralipid will still help to diminish the activity of the NK cells. Okay, back over to the Facebook side. Let's see, what are your thoughts about add-ons for donor egg? HCG wash, PRP, intralipids. Should I do these add-ons at the baseline appointment, midway, or just prior to my transfer. So this comes from Tamara. Hello. So yes, I absolutely would, because when you're using a donor, an embryo that comes from derived from a donor egg, right? You're using really what is someone else's, potentially some portion of it that's someone else's genetic material. So in that situation, your body can mount an immune response against it. And all these things are designed to protect against that immune response. The HCG wash turns up some of the receptivity hormones in the lining of the uterus. PRP wash is probably the most soothing thing that you can put on that lining to make it receptive to the embryo. And the intralipid and all the rest of that stuff that goes with the immune protocol. Intralipid is typically done within a day or two prior to transfer or on the day of transfer, and then can be done weekly through the first trimester. So yeah, Tamara, I definitely recommend that you do those immune things, really to try to maximize your options with that embryo that comes from the donor egg. So absolutely, and good luck there. Our friend Lee Ware is here, and Lee says, what would cause poor visualization of the ovaries? My right side moves and seems like it's stuck or misaligned. Well, so when we do ultrasounds with folks, sometimes the ovaries are in fact hard to see, and anatomically they're usually in the same place, but there is some variation in that. Some scar tissue from prior procedures can cause it to move. Endometriosis can cause them to move and create scar tissue. All kinds of things can do that. But the other thing to really remember on that front is that, what do you suppose occupies the most amount of space inside your pelvis? Is it the ovaries? Sometimes people will come into me and they say, I am so bloated. My ovary must be this big. Well, when you're doing an egg retrieval, you're right. Your ovary may be that big. But at other times, what's causing bloating? Is it because ovaries are so big? No, it's a bowel issue. You have probably 100 times more bowel, intestine inside here than you do ovaries. And so depending on what's going on with the intestine, how much you're digesting, how much gas is in the bowel, how much the bowel is moving around, sometimes that can make the ovaries very difficult to see. And so it's very common on non-stimulated ovaries. And certainly as we mature and our ovaries will become smaller, that later on in the day, if you have an ultrasound, we may not be able to see the ovary at all. And in the menopause, it's very common that we don't see the ovaries at all because they get so small, which is fine because an abnormal ovary will get big. And so if it's big, it's something that we would see. But if it's small, that just means that it can get hidden in all that intestine. Also, in women who are a little bit heavier, sometimes that makes the acoustics of doing an ultrasound more difficult and makes ovaries harder to see. That's one of the things that sometimes will also lead us to needing to do. We talked a little earlier about having to do a retrieval of eggs through the abdomen, and just because the ovaries moved or it's in a difficult position. So it's usually pretty easy to find from above. But in an unstimulated ovary, most commonly it's either scar tissue or it's intestine, it's bowel, that's making it hard for us to see. Good question there. Boy, we got good questions. Thanks, Lee, for that. Let's see. I did skip a bunch there, so my apologies. Let's see. What is PRP, and do you recommend it for transfer failure? This comes from Maddie. PRP is platelet-rich plasma. It is where we take a tube of your blood and separate out your body's tissue components, your healing components, your growth factors. We call these tissue factors. And then we can use that material to place right back in your body for a variety of different reasons. In the fertility world, we use it to treat the uterine lining, which is a very healthy thing for the uterine lining. We can also use it for ovarian rejuvenation by doing intra-ovarian PRP injection under a little anesthesia. And those are all good things. And so it definitely, I do think PRP is a good thing there. Let's see. I think I just skipped a couple here. This comes from Kristen. Hi, Kristen. At what point would a Tessie be recommended? My husband has a very low counts, but this has never been suggested to us. Well, so it really ultimately depends. So, Kristen, you say your husband has low counts, but that can mean differing things. So, how many sperm does it take to fertilize an egg? One, just one sperm. So if we can find one sperm for one egg, then you really don't have to do a Tessie. A Tessie is more, what that is an extraction of sperm directly from the testicle or from the epididymis, which is a portion which is an anatomic structure that sits on top of the testicle. And that's something that a specialized urologist does. A fertility urologist, a regular urologist does not typically do that procedure. If the count is not sufficient to be able to find sperm for your egg fertilization, then we might recommend a Tessie. So one situation, let's say a guy who has had a vasectomy. If he's had a vasectomy and maybe had a reversal and the reversal didn't work, or had a vasectomy and hasn't had a reversal, well, in that situation, usually, there's a gazillion sperm that are all hanging out there. They just have no place to go. So it's pretty easy to get them from the testicle. There are other situations where the testicle may not be making many sperm, and then we kind of want to go and try to retrieve them directly from the source. Because they're not able to come out, they're not being ejaculated. So my guess is, Kristen, if no one's mentioned it, it's probably because the count has been adequate enough that our team in the lab is able to find a single sperm for each egg. But so really, ultimately, it depends on what that count is. What else we got going on? How long before a retrieval do we recommend PRP? How long before the retrieval? So if you're going to do PRP for ovarian rejuvenation, usually we say do it a month beforehand. Some people will do a PRP a month before, and then they will do a retrieval. And at the time of the retrieval, they might do another round of PRP at the time of retrieval. And that's going to help you again for the next retrieval, which ideally you do a month later. So probably about a month before. That comes from Taya Nep, I think that says. MJ Regis, I failed an embryo transfer last May. I did all the immune protocol, but it still did not work. Why did it not work, and what is next? I still have frozen embryos at CNY. Well, and I also see Brickle Barbie is here with us, who was in our office today. Hi, I hope you're feeling well after your retrieval. So to answer the question, why did that why did that transfer, MJ, why did the transfer not work? Most commonly, if a transfer is unsuccessful, it usually has to do with the fact that there's something that was chromosomally not normal with the embryo. So every embryo we make, unfortunately, will not be normal. And there seems to be a little kind of misconception out there that folks will go and do their IVF and they'll make embryos and they'll put an embryo back in and they're supposed to be pregnant with that first embryo. Sometimes that does happen, and it's great when it does. Gosh, we love it when that happens. But in reality, just like in nature, every embryo that we make either in the laboratory or that you make in your body, every embryo will not be a normal embryo. And if it's not a normal embryo, then in most cases with IVF, it doesn't stick. So that's the most common reason that someone doesn't have success with an individual round of an embryo transfer. It is a numbers game with an untested blastocyst. That's like a day 5, day 6, or day 7 embryo. We tell you it may take 4 blasts in order to achieve a pregnancy. Even with a tested euploid normal, chromosomally normal embryo, we tell you we expect that it may take 2 embryos for you to be able to get pregnant with it. So it doesn't work every time, but certainly, God willing, it will work some of the time. And so hopefully we can get you there, my friend. Oh, let's see. A few more questions. We have a couple more minutes, or maybe just one more minute. Bonnie Raider says, does Manjaro affect egg quality in a negative way or a positive way? Well, Manjaro or the GLP-1 agonists like Ozempic are not supposed to be used when you're trying to get pregnant because they haven't been studied very well. I suspect at some point they will be studied better and will have differing recommendations on that. But I have not seen any evidence that points to specifically what they do for egg quality, but with pregnancy, they should be avoided. Airly.cn says, when implanting an embryo, are there any medical reports or experiences that indicate which part or depth of the uterus will increase the chance of pregnancy? Or is this just usual standard practice? So as I mentioned before, usually we place that embryo, we want it to be going in approximately 2 centimeters or so below the fundus, the top part of the uterus. So we place the catheter just inside the opening of the uterus and let the media that the embryo is in, and let the embryo find its most comfortable spot inside. Guess what time it is? I'm sorry we're out of time, but we still have so many questions to get to. Please come back next week, won't you? It's a top of the hour now, and just like every Tuesday at 4 p.m. Mountain Time and 6 o'clock on the East Coast, it's Fertility with Fink and Friends. I'm Dr. Randy Fink, the Clinical Director of IVF Services here at CNY Fertility, Colorado, and the Medical Director at the Miami Center of Excellence in South Florida. And let me just say, it is always a pleasure to be with you. Thanks so much for being here. Remember, as I am fond of saying, infertility is not your book. It is not your novel. It is merely a chapter. And what we're here to do is to help you rewrite it. So until next week, thanks again for being here. God bless and good night.